Hi, good afternoon. My name is Dr. Bismruta Misra, and I'm the Medical Director of Stanford Health's Diabetes and Endocrine Center and Osteoporosis Center. It is my great honor to present our fourth speaker in our surgical medical education series, Dr. Rudolph Taddonio, who will be speaking about orthopedic back and spine surgery. Dr. Taddonio is one of the most well-known and respected orthopedic surgeons in our area. As I've mentioned in the introduction to our other speakers in the series, many people, including other doctors, think of surgeons as doctors who simply operate. And what they don't realize is how much screening and prevention work they do in their office and how much they will work with patients, sometimes to prevent a surgery from happening. And Dr. Rudy Taddonio is a perfect example of this kind of surgeon. Dr. Taddonio completed his orthopedic surgery residency at New York Medical College and Metropolitan Hospital, followed by his fellowship in spine surgery at Rush Presbyterian, St. Luke's Hospital, and Shriners Hospital for Crippled Children in spine surgery. He is director of the Scoliosis and Spinal Surgery Center at New York Medical College and vice chair, Department of Orthopedic Surgery. And in all of his free time, he's also medical staff president at Stanford Hospital. I know Dr. Taddonio is a caring doctor who thinks about the whole patient and as a snappy dresser who always wears the best bow ties. You should look at the one he's wearing now. Please welcome Dr. Taddonio. You are in for a treat.
Thank you, Dr. Misra. I'd like to plug Dr. Misra. She is my go-to endocrinologist. So I'm a spine surgeon, a spine doctor, and when I see patients that have osteoporosis, she's the first person that I think of to send them to. And her spine osteoporosis, really an osteoporosis center, is here in New Canaan and in Stanford, and she has a wonderful team that concentrates just on that. So I recommend her highly. Well, good afternoon, everybody. Thanks for coming this afternoon, rather than playing golf, which is what you should be doing. It's such a beautiful day. I'm going to talk to you about spine problems. Back pain is probably the most common thing. My practice is devoted to all age groups. Half my practice is devoted to children with spinal deformities and scoliosis, and the rest to adults with the same issues, and as well as back pain and neck pain. Believe it or not, only 2 in 10 that come into my office actually require surgery. We see many patients who get better without bringing them to the operating room, and only in dire circumstances when their quality of life, their neurologic function and pain is so severe that we recommend surgery. So what about back pain? Who in this room has ever had back pain? There you go. Well, it's about 80% of the world has had back pain one time in their life, or even 2 or 3 times in their life. And 25 to 30% of patients that have back pain seek medical help. We have 58 million ambulatory care visits for back and neck pain in this country, and 82 million workdays lost. That's an enormous burden on our economy. We have to understand back pain in order to treat it as physicians, in order for you, patients, to understand and decrease some of the anxiety around it, which can be very high. We need to diagnose the causes of the pain and then understand who's at risk and try to mitigate those risks. There are many therapies, medications, surgery, non-surgical treatments, and complementary approaches. A little lesson in spinal anatomy, and I brought along Sally's spine and her little brother over there. So if anyone wants to just pass them around and sort of get a feel for it, they're plastic, not real bones, so not to worry. But this is what the lumbar spine looks like. This is the sacrum. These are the big lumbar vertebra and all the ligaments that are attached that keep everything together. The disc spaces are in between the bones, and they act as cushions. And without getting too technical, the disc is made up of a hard outer ring and then a soft center which attracts water. It's like a jelly donut. And as we get older, and we start getting older, believe it or not, when we're about 15, our discs begin to lose water content, especially in the nucleus area, when we're about 15. That's a scary thought. The disc resists compression, rotation, flexion. It has tough ligaments. It has overlapping fibers, and you can see this is I'm sorry. It's not going to work. That's a normal disc. This is the jelly that absorbs water, and this outer portion here is the tough ligamentous structure, the ring around the jelly donut. It degenerates with aging. The outer third is what's innervated, just on the outside. The inside has no pain fibers, and the blood vessels in there are rare. You can see all the blood in the bone around it, but the blood vessels in the disc are very rare. So the disc gets its nutrition through osmosis, meaning the creeping movement of nutrients through the bone into the disc space. And as we get older, that happens less and less. As our bone loses some of the marrow in the circulation to the disc suffers. Nicotine use, diabetes, where there's a vascular compromise to all the small blood vessels in our body. Therefore, we get less nutrients to our bone, less nutrients to the disc. The normal disc moves forward and back, and the nucleus moves forward and back with that motion. If you bend forward, the nucleus, the center moves backwards. If you bend backwards, the center moves forward. That's supposed to be a little motion picture, but it doesn't work. So this is a young disc here, young spine. This is a cadaver preparation of a very, very young disc, and you can see the nice, juicy, healthy disc. Those are the bones. This is an older spine. And you see what's happened here. You can see that that disc looks a little friable and fragmented. There's a bulge. The ligaments are thickened. You don't have a lot of room between the back of the spine and the disc. And this is aging. This is basically what happens to all of us. And again, it starts at about 15. Normal spinal alignment from the back to the front, we should look like that, and we should look like this. We all have a normal cervical lordosis, a thoracic kyphosis, and a lumbar swayback or lordosis. This is the front of the body and the back. This is good posture, with our head balanced over our sacrum. So who's at risk? Well, we're all at risk. If we sit too much, if we work too hard, if we lift too much, if we're overweight, if we twist, we carry, and we're out of shape, we're at risk to have back pain and to injure ourselves. If we don't exercise regularly, it doesn't matter what age you are, regular exercise suited to your body type, suited to your health status, and your age is very important to stave off the incidence of back pain and the disability associated with it. Smoking has a very high incidence of back pain. Smokers have a 50% higher incidence of back pain than non-smokers. If you look at x-rays of the spine of smokers, they have twice the amount of degeneration and arthritis as non-smokers. And the same thing with diabetics. That's because the microcirculation, the small vessels that go to feed the tissues around the joints in the spine get squeezed down, they get constricted, and those tissues don't get the nutrients that are appropriate for good health. So what are some of the presenting symptoms? If any of you in this room have had back pain, you know you can have stabbing, shooting, throbbing pain, spasms. You can have pain that shoots down both legs or arms if you have neck pain. You might have a numbness or weakness, which are, troublesome signs. You can have pain with walking or sitting, bending. You may have interference with your sleep. It may wake you up in the middle of the night when you roll over. You may find yourself twisted off to one side because of spasm. Red flags, however, are pain that wake you in the middle of the night out of your sleep for no reason, and incontinence of bowel and bladder. If you're incontinent along with back pain, that's a red flag. You should see a doctor immediately. So, who should you see? Well, usually I'm an orthopedic surgeon. I think an orthopedic doctor is probably the best suited to examine a patient with back pain. We're guardians of the musculoskeletal system, if you will, and back pain is a musculoskeletal problem. There's some period of activity modification which is recommended, but not a lot. We have found that years ago, patients used to be put in bed for 10 days or 2 weeks. All it did was push their recovery out further than necessary. So decrease in activity, but activity, activity modification is very important. Medications such as anti-inflammatory medications, Tylenol, heat, ice, local salves on the back, a lot of things you can buy over the counter. We don't want to start patients giving them narcotics right away because that's not a good thing to get started on for back pain. Narcotics, opioids, as you know, can lead to addiction, and there's a terrible problem in the country now with opioid use. What do we do when someone comes into the office? First is examination, of course, and the history. We do a neurologic exam. We test their strength, their reflexes. We do x-rays if necessary, if they have long-standing back pain, or they have extremity weakness or pain in their extremities, arms or legs, we get an MRI. We can also do a CAT scan if necessary, and other work that is appropriate for the condition. The first line of treatment is to get the patient rehabbed. So most patients who don't have progressive neurologic issues such as weakness or numbness that is progressive or loss of bowel and bladder control, we get them into a rehab program. I particularly like to strengthen the core. The core is not just around your abdomen. It's your legs, it's your neck, your shoulders, a total core program. It can be initiated by a physical therapist under the directions of a prescription. And then we want to get the patient to have increased endurance. You can graduate from that to an independent program. Pilates, yoga, walking is a great exercise. Riding an exercise bicycle is a great exercise. All these things that increase your aerobic fitness and endurance, all in the end will help your musculoskeletal system withstand the stresses of everyday life. Again, we talked about the medication, analgesics, anti-inflammatories. The common anti-inflammatories are over-the-counter, Advil, Aleve, Motrin, ibuprofen. Some people can't tolerate those. We have to use other things. Occasionally we'll use a steroid pack to sort of get rid of the pain. Rarely we'll use anti-anxiety agents and antidepressants or sedatives, and muscle relaxants can be used for a short period of time. Some of the conservative treatments, besides exercise and rehabilitation, are injections. If any of you in this room have had back pain for a while, you know that an injection can help, whether it's a trigger point injection of cortisone and a local anesthetic, or an epidural spinal injection, or facet injections, which is a needle into the little facet joints. And if you have a spine that you're passing around, you can see those little joints. They're the gliding joints. They're the same kind of joints we have in our finger and our hip and our knees. And they get arthritis. And sometimes injections can help back pain with that. And then nerve root blocks. You can take these needles and move them over a little bit when the nerve comes out and inject the medication around the nerve, and it will alleviate leg pain. Any questions so far about what I've said? I know it may be a little technical. It's kind of an anatomy lesson.
Is there any danger in injection around the nerve?
Well, there's always a danger. However, it's very, very slight. The person doing it is skilled, and it's done under X-ray control. Most people just don't, stick a needle in and inject. They'll use an image intensifier or a fluoroscope. in their office or their little surgery center and see where the bony anatomy is, and then off a millimeter or two from that point in the two projections, the front and the side, they can inject, and that's where the nerve will be. So done correctly, there's very little danger. I've sent thousands of patients for injections, and I can tell you that I think probably the complication rate, infection or hitting a nerve is 1 in 10,000. It's really low.
But if it does hit the nerve, what is the...
Well, if you hit the nerve, it's immediate pain, but then it dissipates. The damage is not permanent. Yeah. Yes?
Is that procedure done by the surgeon or by a technician?
Most surgeons don't do that. It's done usually by a pain management doctor who's either an anesthesiologist or a neurologist or a physiatrist. It's done by a physician, yes. No, you wouldn't want a technician to do that. That's not really technicians' aegis. So I'm a surgeon, and I've operated on 6,000 patients. I've seen a lot more than 6,000 patients to get that many. And however, when surgery is necessary, it's because the leg pain is a real problem. That's the primary symptom, and we can work on the back pain. And most patients, if you approach the back pain conservatively, get better. But the leg pain doesn't get better because there's impingement on a nerve. We have to examine the patient, and the symptoms that the patient has to match the findings on examination. If we do an exam and we can't reproduce those exact symptoms that the patient is complaining about, we're not dealing with a situation that requires surgery. Because if you operate on what you see on an X-ray or an MRI, the patient's not going to get better if the examination doesn't match the symptoms. So we do minimally invasive surgery through little tiny incisions in the microscope. We can take away compression of nerves by doing what's called a laminectomy in patients who have spinal stenosis. Stenosis means narrowing. The nerves are compressed. Patients have difficulty walking. They walk bent over. They'll walk like this, and then they have to stop and bend forward even more, or sit down for the leg symptoms to go away. We can also do instrumentation. We can put rods and screws in spines. And one of those little models I sent around has a small example of rods in the vertebra with a little spacer in between that stabilizes the vertebra and stops the motion. And then we can correct spinal deformities such as scoliosis or kyphosis, whether it be in children or adults. So this is just a brief case. This is a 41-year-old female with a large herniated lumbar disc and severe back pain and a foot drop. Her nerve was so compressed that when she walked, her foot flopped. And then she couldn't lift her foot up. She really had a paralyzed muscle group in her leg. That requires surgery. And this is just an example of, oops. Sorry about that. Pressed the wrong button. This is just an example of the herniation, big bulge. This is the bundle of nerves being pushed all the way over. This is the back of the spine again. That's called the lamina. That's the disc. And this just didn't get better with time. She had an injection, she had therapy, she had anti-inflammatory medications. It didn't get better. And when we look at patients who have this problem, if they don't get better in 3 to 6 weeks, then they're candidates for surgery. Unless they have a progressive deficit neurologically, then we operate on them sooner. This is an MRI. Again, this is what we call the axial view right here, like you'd slice a loaf of bread. There's the big disc herniation here, occupying 50% of the spinal canal. These are the nerves that are pushed back here. And this is another big disc herniation that's come out of the disc space. These are the bones, the disc, and this big goober of disc material is pushed all the way back up the spinal canal. These patients require surgery. Yes?
Actually, when it's herniated, it goes toward the back, not front?
It goes towards the back, yes. If it goes towards the front, nothing happens. There's just retroperitoneal, there's just abdominal contents there, and it's not big enough to cause any issues. It can cause back pain, but when it goes towards the front, that's not a problem.
But it does go toward the front?
Rarely. It usually goes to the back because the back of the disc, where the ring is the weakest part of the disc. And that's the part that gets damaged and torn. When you think about the mechanism of herniating a disc is flexion and rotation. Bending into the trunk of your car and pulling something out. Going in the garden and trying to pull out a root. If your gardeners get a cushion, kneel down on the cushion and work in front of you without a lot of twisting. Because it's the twisting and the bending forward that damage the disc. This is spinal stenosis. This is what, if we all live long enough, this is what we get. You see these are very big joints back here. This white area is the spinal canal. It should be 2 to 3 times bigger than that. So the nerves are all squeezed in there. And when we walk, our brain sends a signal to the nerves and says, fire, send the message to the muscles in our legs. It happens, but the nerves get fatigued because they're not being fed enough nutrients. And then as you walk with spinal stenosis, you get numbness in your legs, they get heavy, they get wobbly, and you have to stop and sit down. This was one of the classic signs of spinal stenosis. These cases require removal of this part of the vertebra to open everything up and to get the circulation back to the nerves. I mean, arthritis of the spine, we talked about the little joints being arthritic and how they can have injections. And then there's this other problem we see more in young people. It's a stress fracture. Again, this is a CAT scan. That's the vertebra. This is the spinal canal here. All the nerves pass through. And you can see this little separation. That's a stress fracture. And you can see it here. What happens is, this is the vertebra above. This is one piece. Everything's connected. This is not. So this piece can, with time, move forward and cause a slip. And that's called spondylolisthesis. A little technical, but this is what it looks like here. This is this vertebra. This is the bottom of the sacrum. If you have the spine in front of you, you can see the bottom of the spine. But this vertebra is slipped forward because it's lost the bony hook that's keeping it back. This can get worse with age, can cause leg pain, back pain, and requires surgery because of instability. And this is what we do. And that's what's in that little clear plastic model that was passed around. We use a computerized device to put the screws in. Everything is on a big screen, almost as big as this, in the operating room. And we can place a cursor on the bone of the spine, know exactly where we are, and know how deep we have to push, screw this into the vertebra, the maximum diameter, and the direction to make it very safe. Because you can imagine, there are nerves here, there are nerves here, there are nerves in the middle. We want to be absolutely precise and perfect when we're putting a screw into someone's vertebra. This is a complex problem with a patient who had an old fracture, and you can see that they've developed this, what we call a swan neck deformity, spinal cord compression, and so we had to modify that and do some, we call osteotomies, and put cages and plate, and then screws and rods in the back. One of the more complex things that we do. Scoliosis surgery. This is what we do in adolescents and young children as well as adults. This is a curvature of the spine that's progressed. We use lots of screws and rods and make the spine straight. I won't get into this. This is just a picture of what the patient will look like after. You can see the waistline asymmetry and the nice straight spine after surgery, and this is the result. I'm not going to show you any more of these. It gets boring. there any questions? Yes.
Is that spondylolisthesis, because I had that at the L5S1,
Yes.
which is in my 20s. Is it always L5S1 or is it?
No, it can be at L4-5 also. The most common place is L5S1, but also L4-5. And there are certain types of spondylolisthesis, which in Greek means slipping and sliding of a vertebra. There's the degenerative spondylolisthesis, which we see in adults, and in adults over 50 normally, where they get spinal stenosis, and then they have to be fixed. Or there's what we call isthmic spondylolisthesis, which is present in about 5.5% of the Caucasian population in the United States. And it occurs probably around age 4 or 5. It's not symptomatic, yet the patients become symptomatic after.
I never really thought I did anything to break it. Just kind of like...
There's a hereditary predisposition.
That's what they said.
Yeah, 40% of family members of patients who have spondylolisthesis with a stress fracture have the same problem. The incidence among gymnasts is about 13%, divers, wrestlers, it's double, plus, because of the stresses that they have on their spines and during those activities.
When the pain gets chronic, you manage, you do surgery on it also?
Well, it depends. You know, the patient who has chronic pain, we have to look at where the pain is coming from. Okay, if they have chronic nerve pain and weakness for a year, sometimes the pain doesn't go away because the nerve has become damaged. So we do electrodiagnostic studies to see how much damage there is to the nerve. So there's a neurologist normally will hook the patient up to little electrodes and stimulate the nerves and get a reading on it's like an EKG of the nerve to see how it's firing, what sort of potentials, electrical potentials there are, and if it's chronic or acute and what degree is. If it's very, very chronic, a lot of patients don't get the full relief they should. So if someone has arm pain or leg pain that's greater than 3 months and just hasn't gone away with our conservative management, I usually recommend surgery because if it goes on for more than 6 months, then the surgical result is usually not as good. Chronic back pain is another issue. There are patients who have chronic back pain that have risk factors that mitigate against them getting better. They may be overweight, they may be out of shape, they may be chronic smokers, they may have osteoporosis, they may have severe osteoarthritis. I have some patients in their 40s with terrible osteoarthritis. They've had hip replacements and knee replacements. And if you look at their families, their parents have had the same problem. So a lot of what goes on in our musculoskeletal system can be hereditary. So there's another couple of slides here on okay. It's not working. There we go. So exercise. How are we doing on time? We're good. Okay. So really, one of the things I push with patients is exercise. I think that exercise, again, as I said at the beginning of the talk, suited to your body habitus, your age, your lifestyle, and other conditions you might have. You know, people who have arthritis may only be able to exercise a little bit, or only do certain types of exercise. For example, running. Running is not good unless you're a kid. You know, it just doesn't work. Think about what you do when you run. All your body weight's coming down, starting right into your ankles, your foot, your ankles, your knees, and your hips, and even your neck. Slow motion studies of runners, you can see their necks doing this every time they run. So all the joints in our body are affected by running. Now, there are some people who are genetically blessed. There's some people who run the marathon, they're 75, 80 years old. They have a different type of musculoskeletal system. But for most of us, it's the low-impact aerobic activities which you really should participate in. Walking, even walking fast, exercise bike. If you go to the gym, you can get on the weight machines, no free weights, no kettlebell. Not that anyone here is using a kettlebell, I'm sure. But you know, I see all these injuries from patients in their 30s using a kettlebell. All that twisting.
Do you have facilities, for example, the Y, if they have group exercise or whatever that is geared for people who...
Yeah, they do. Many Ys have group activities graded for certain age groups.
But also that might be, you know, I find the lower back, you've got to be careful. You mentioned the core, but if you're not careful, what you end up doing is aggravating.
Yeah, well, it's doing the exercise correctly. And there's a handout in the back about exercises, and there's a check mark next to the good ones and a cross next to the ones that are not good. So I encourage you to take one home and look at them.
You say, you know, like I do, like the trunk turns with the cable machine.
Yeah.
The strength
Well, that's okay, as long as first of all, as long as you're standing up straight
is straight, right?
and not bending forward, and that you don't overdo it.
So the bending ones are bad if I go at full.
That's right. The bending and twisting is not good, and over twisting is not good. Yes.
How do you feel about a treadmill? Because that, maybe even if you're doing fast walking, you should control the, you know, the
Yeah,
incline,
yeah.
the speed.
I think a treadmill is perfect, especially in this part of the world where we have inclement weather for 4 or 5 months out of the year. You're not going to go out and walk if it's snowy and icy. A treadmill is great exercise. Not only is it good exercise because you can work up a sweat, you can get aerobic exercise walking fast, but it's good for your bones. Weight-bearing exercise is appropriate to drive calcium into your bones and decrease the bone loss and therefore osteoporosis. So it's very important. Yes?
Is the back pain always caused by the nerve or the muscle, which muscle can cause the back pain also?
No. Back pain starts with the joints. The disc is one kind of joint, and the little facet joints, those little gliding joints, are joints like we have in our fingers. They become arthritic. They have capsules. They get inflamed. It's like having an arthritis in your hand or your knee. When the nerve gets involved, it's because the swelling that takes place and the inflammation that takes place is very close to the nerve, and then the nerve resents that, and you get pain in the nerve. Or there's direct pressure on the nerve. Yes, sir.
How about ellipticals?
Ellipticals are good also. I recommend those. That's a great aerobic workout. If you want to avoid the twisting, don't use the arms. Just use the stationary part. It's excellent. Yes, ma'am?
If you take pills for joint pain,
Yes.
are they effective?
Well, you know, I've been taking them for 20 years. They seem to work for me. There have been some studies, good studies that show that yes, they do work, and some studies say yes, they're no better than placebo, but they certainly can't hurt. There are no side effects from the glucosamine, chondroitin, MSM pills you can get over the counter. And if you tolerate them, I think that I advocate them, quite frankly.
Oh, thank you.
Yes.
You said not to lift free weights. Are you talking about men with the heavy lifting? You're not talking about.
Well, I think if you're lifting 2 to 5 pounds and doing these toning exercises, that's fine. It's when you're bending over onto the weight rack and you're picking up 25, 30, 40 pounds, and then you're moving away from it. Those are all the things that are bad for you. Number one.
Is that at any age? Or
Yeah.
just
I have kids in my practice. They're in the weight room. I tell them, use the machinery. You can get the same workout with machinery and isolate the muscle groups you want to work on than with free weights. And so many people are unbalanced when they use the free weights. Whereas with the machinery, you're sitting or you're standing, and you have it's a whole different structure that you relate to the machine with rather than free weights. I mean, I go to the gym and I see people using free weights and they're rocking around and they're twisting. You know they're going to hurt themselves at some point. So, again, the running's no good. Tennis is fine at a certain point. At a certain point, play doubles. I mean, I think tennis is great, but play doubles. There's a guy on a treadmill, and these are some of the exercises. Okay, you can bend forward, but not too much. these exercises that sort of strengthen your core, gentle rotation. This one over here to the right and the bottom is a good way to strengthen your core, and the straight leg raising this to stretch your hamstring. No, it's not working.
Doctor,
Yes.
what is your opinion of the Pilates reformer machine?
I think it's torture. I've been on it. I mean, I think, you have to be careful. Your instructor needs to know, needs to assess your musculoskeletal function and know what you're capable of doing. The reformer machine can hurt. You got to be a little careful with it. It's great. If you can tolerate it and you're young enough and you don't have frail bones, it's probably a good machine. And I've used it. I did Pilates for a while. You can strain. You can get strained. You can, yeah. Yes, sir.
I wonder if you could demystify the benefits of the teeter hang-up.
The what?
The teeter hang-up. Have you?
Oh, the inversion.
It's an apparatus in which you place yourself and then you turn yourself upside.
Yeah, the inversion machine.
Yeah.
All right. So the inversion machine, it's not a myth. There's a mechanical reason for it. Okay. It uses your body as countertraction. So your body weight is pulling the discs and the joints apart. All right? The same thing as if you go to a physical therapist and they put a little band around your waist and give you traction while you're lying down, or they do traction in your neck, manual or mechanical. The chiropractors do the same thing. They have traction machines. It's safer to be on your back than upside down. No. There's a lot of reasons. One, you could fall and break your neck. Two, if you've got high blood pressure, the blood rushes to your head. If you have a brain aneurysm that's quiet, nothing's happened, guess what? I mean, it's just, again, I don't recommend it. And it does work, but I think that there are other things that work just as well and are safer.
You mentioned that a machine that does that same thing. I think we've seen ads in the paper that they have a machine that is supposed to stretch out and create spaces between.
Yes, yes. Well, what it does is it stretches the disc, but more important, what it does is it stretches the little capsules around the facet joints, those little joints. And that gives you a little relief because those capsules get stiff. So when you're stretching those, and that can cause you back pain and stiffness, that helps relieve that. The discs are, they can be opened up, and you need 3 times your body weight to make a difference in the disc height. So if you weigh 125 pounds, you need 375 pounds of traction to open up the disc space. So it's really not so much that. It's more the little facet joints as a source of the back pain. Yes, ma'am.
I heard that if you lie on the bed without a pillow or just lie flat, or on the floor just flat, it's supposed to help your back.
Yeah, well, if you look around the room, is anyone else here, anyone in this room flat? Anyone have a flat back, a flat front? No, we don't. So when you lie on a bed, well, that bed has reaction forces from the mattress, so you're not flat. When you lie on the floor, that's flat and hard. And I don't know, some people may get relief from that, but I don't see how. I think when you're in bed or you're on the floor, it's probably good to have a pillow under your knees, and I don't know how long you can stay on the floor. Yes?
How about transitioning to swimming as an exercise from the ellipticals or?
Yes.
Is that complete, first of all?
No, it's not. However, it's very good. Swimming is a non-weight-bearing exercise. It's good because you're stretching. You're using symmetrical motions in your body, so it's good for your core. There's not a lot of rotation, although the flutter kick can cause some rotation. You can be on your back. The problems come in if you have to extend your spine, and especially your neck. If you have spinal stenosis, narrowing again in your neck or your lower spine, extension is no good. So if you're going to swim with a snorkel. So your head is down like this, you don't have to lift it up and move it out of the water for patients with neck pain. If you have spinal stenosis in your lower back, you can swim on your back or your side. However, just that as the only exercise you do is not the best thing, because you need weight-bearing exercise in order to, again, push calcium into your bones. Swimming is, there's been lots of research on swimmers and people who don't swim and walk. The walkers have stronger bones.
Okay, so you supplement swimming
Yeah.
with...
You can cross-train, it's great.
Thank you.
Absolutely.
For back exercises, like I shouldn't do this, but I do like deadlifts, just like 10 pounds like this. That's obviously bad. Just to do
That's
that.
not good.
No?
No.
Should I do those like back machines where you like push back?
That's right. That's a better machine, okay? Those machines are great because you can not only do the machine where you push back, but you can also do push forward. If you do,
That's better than me doing that.
that's better than you doing that, yeah. Because you're flexing your spine. You're increasing your intra-abdominal pressure. You're increasing the intradiscal pressure. And guess what? The nucleus, that little center, is being pushed back.
Well, plus I have ankylosing spondylitis. I have that too.
Oh, you do?
Yeah. So, I mean, my spine.
You're stiff.
Yeah, I'm real stiff. So I stretch and I do lift just
Yeah.
to the bone machines. I'm trying to find the back exercises that.
Well, the machines that have those, the abdominal, those are good machines.
Bend down and from the floor and pick up.
Yeah, right.
It's really resistance training as opposed to weight training.
That's correct.
Resistance training is good, weight
Yeah.
training is not.
Isometric exercises can strengthen you, they can tone you. You may not feel like you're doing as much, but they can work also. And I start, when I have a patient who I've operated on and we want to get into physical therapy, I start with isometric core programs. And then gradually, after about 6 weeks, get them into more resistive training. Yes, ma'am.
Taking calcium pills, if you have back pain, does that help, or is that not enough?
Calcium and vitamin D are for our bones, all right? Our bones will be leached of calcium to sacrifice where calcium is needed. It's needed for muscle contraction, it's needed for our heart, so it will be taken out of our bones. So we need, as adults, we need between 12 and 1,500 milligrams of calcium daily. You can get that from 5 glasses of milk if that's the only source. You can get that from broccoli, vegetables, sometimes the water, if you have well water, might have calcium in it. But you can see there's every food we eat these days has a list of what's in it. So I recommend that, I did a study with my adolescent patients. We gave them a disc, and it had all the food groups on it, including McDonald's, all the fast foods. Only 20% of them got enough calcium in their diet. So we're seeing that a lot. Yes, ma'am.
If you're low in the vitamin D, is it necessary that you would be low in calcium?
No, you may not be low on calcium, but if you're low on vitamin D, the calcium isn't getting into your bones. It's being excreted in your urine. So if you don't have enough vitamin D, and we in this part of the world, it's seasonal. If you go out in the sun for 10 or 15 minutes a day, you get 10,000 units of vitamin D. That's without sunscreen. Now, we're all putting sunscreen on because you don't want to get skin cancer. However, sunshine is pretty good. Today's the first sunny day we've had in about 2 weeks. No, that was Dr. Van Beek. I'm a spine doctor. I know, but she's not here. I'm sorry. Yeah, I know. She had to cancel at the last minute. She had a personal issue. I saw her just before.
What happens if you go to an orthopedic surgeon and you're a certain age? You know you have degeneration in your spine and so forth. And they say to you, well, degeneration is normal with aging. So I've come across that, and I have felt at this point that maybe I should, when I fill out the patient information sheet, I should take 20 years off my life.
Falsify the birth date.
It's your age. It's normal, but you still have a lot of pain.
Yeah. Well, I mean, I think it's probably unkind to say, oh, you're old and that's not nice. No, but they,
With aging,
yeah.
you have degeneration, but you still have pain.
Yeah, well, you know, degeneration, I see patients that have degeneration sometimes on X-ray.
But then you don't do anything.
They don't have pain. And they don't have pain. Yeah, if you do, then you need to find the source and see if you can mitigate it with some of the things we've talked about. You know, not everybody can get relief of their pain, but the majority of patients can, without surgery too. Yes, ma'am.
You said about sun and vitamin D. How much of our body needs to be exposed to the sun to get there?
Oh, good question. I'm not really sure, but I think probably just your arms is enough. You know, if you're worried about your face, you put it on your face.
I'm sorry, would you repeat the amount of calcium she has daily?
12 to 1,500 milligrams daily.
Okay.
And if you're someone who has kidney stones, well, you've got to really talk to your doctor before you start loading up with calcium. And then we do need, although it hasn't been established how many international units of vitamin D, we probably need between 1,000 and 2,000 daily. There are some patients who have significant vitamin D deficiency that put on 50,000 units twice a week. And we see this. I see patients, we do vitamin D levels on every body that we operate on. And I would say that in the winter, 80% are low, kids and adults. So we are supplementing for healing of spine fusions, we're supplementing their diet with protein, vitamin D, and calcium. In fact, in trauma centers now, everybody that comes into a trauma center that has orthopedic surgery for fractures gets put on vitamin D. We're finding that the incidence of delayed unions and non-unions, meaning that the bone doesn't heal, is decreased if the patients are put on vitamin D. So, you're welcome. Well, thank you very much. Any other questions? Good. Well, enjoy the sunshine. Get your vitamin D.